Good evening, all, and I'd like to thank Chennai Arthroplasty Club and especially Dr. Arun Kannan for giving me this wonderful opportunity, and my good friend Kalai and other good friends in Chennai. And we published this article in the last month in Journal of Indian Journal of Orthopedics. So our research title was "Does Total Arthroplasty Affect Ankle and Hindfoot Alignment?" So basically, it's a prospective study and functional radiological outcome. So if you look into this X-ray carefully, so does both X-rays show the same alignment? So just by looking into the short film, it shows not doesn't show much difference. But when you look into the long film, definitely there is a difference in case one and case two. If you look into the case one, definitely there is a change in the ankle alignment. So if you look carefully in the picture number one, and case number two, you can see the axis which passes through the shaft of the tibia to the ankle is a bit neutral. So this one it should be always assessed in pre-op evaluation. So coming to the normal knee-ankle relationship, the weight-bearing axis run through the center of the knee and the ankle. Normally the heel is in slight valgus related to the talus. So coming to the biomechanics, so we classify hindfoot valgus as a physiological and pathological. The range between 2 to 6 degrees is a physiological range of hindfoot valgus, which is more than 6 degrees is a pathological hindfoot valgus. So, what is the effect of the knee deformity in ankle and hindfoot? Always there is a compensatory tilt of tibia. I'm talking about a varus knee because majority of the case we routinely deal with a varus knee. So always there will be a compensatory tilt of tibial joint, and there will be abnormal forces acting on the ankle and hindfoot. So which leads to a subtalar valgus, especially in varus knee. And in valgus knee, there will be a subtalar varus. So if it is persistent or any abnormal force which is acting for a long time, or especially in rheumatoid, those patients they may land up in an ankle osteoarthritis. But this will be the effect of the knee deformity in ankle and hindfoot. So this is basically a dynamic trio. We all know that the one joint will affect the other joint. So this is the overall the overview of this, how it affects the other joint. So we did a literature search. So definitely there is a paucity in the literature regarding the knee ankle hindfoot syndrome. So what is the need for this study? So we all know that around 10 to 30% of the patients are dissatisfied following total knee arthroplasty, and we found that one fourth of the patient who undergo total knee have some ankle symptoms, but we have to pick it up and examine clinically, and we have to see whether the knee is contributing for the ankle and how much we can rectify issue in intra-op and post-op. So aim of the study to study the influence of total knee arthroplasty in ankle and hindfoot alignment radiologically and functionally. Our study design is a prospective case control study. uh, the study period is between 2020 to 2022, and we included a 66 patients, totally arthroplasty around in 87 knees, and majority of them were in a varus knee, and only the 4 patients we included as a valgus knee deformity. So our inclusion criteria were the patient undergoing totally arthroplasty in the grade 4 osteoarthritis, both varus and valgus. We excluded revision arthroplasty, inflammatory joint disease, and post-traumatic osteoarthritis. So we did a routine clinical examination, and we assessed the flexibility of the hindfoot by using this Coleman block test, whether it's a rigid or flexible hindfoot. And radiologically, we assess the following parameters. The number one is an ankle assessment, and second is a hindfoot assessment. And the first one we all routinely do in a long leg film, the HK angle we calculated, number one. Number two, we calculated the ankle assessment. The three angles which we measured is a number one is a tibial plafond inclination angle, and which is the tangential line passed up parallel to the tibial plafond, and the vertical line to the floor, which forms the angle, is a tibial plafond inclination angle. And number two is the same the tangential line passed along the talar dome, and which forms the angle perpendicular to the line vertical to the floor is the talar inclination angle. So when we and third one is the angle between the tibial plafond and talar, which is called as a tibio-talar tilt angle. These three angles which measure for the ankle alignment. And the third one we assessed is a hind foot alignment. This is very important. And for that, we took a special X-ray, that is a long axial view of hind foot. In this, anatomical shaft axis of the tibia has been marked, and second line is a line which is passed through the axis of the calcaneum with reference to the end of the calcaneum with two reference point. One is 7 mm from the end of the calcaneum, another one is a 3 centimeter from the end of the calcaneum, which passes through the axis of the calcaneum, which forms the angle, that is the hind foot angle. This is very important, so that if you know this, we'll be able to. Sorry, am I audible? Is it
Yes,
okay?
you can proceed,
Yes,
sir.
yes,
Yeah.
yes. So this is the third angle which we measured. The functional outcome score, pre-op at 1 year and 2 years follow. We use this American Orthopedic Foot and Ankle Orthopedic Score. It includes three parameters: pain, function, and third one is alignment. So out of 100, we scored, depends on the patient's assessment score in the follow-up. And this is the pre-op radiograph, which I already explained. The long leg scanogram and ankle alignment with the three angles. And third one is a hind foot alignment angles. And post-operatively, the same, the long leg scanogram was taken. And again, the ankle alignment was measured in the post-op. And the third one is a hind foot alignment was measured in the post-op follow-up in all our patients. Our result analysis showed the mean age is around 65 years, predominantly females, and majority of the patients were the unilateral total knee replacement. Our results showed around 43% of the participant had a pathological hindfoot valgus alignment preoperatively. So that is the angle in the hindfoot alignment is more than 6 degrees, and in which the four valgus knees, among the valgus knees, the two patients had a hindfoot varus. The hindfoot varus, which is angle less than 2 degrees, and two patients had a hindfoot valgus. And this is our result analysis in the particular to the influence after the correcting, because we targeted for a neutral mechanical alignment. We do a conventional technique and no alternative alignment philosophy. And the influence of total knee arthroplasty and ankle joint, and with the corresponding to all three angles, there is definitely a correlation in relation to the ankle was statistically significant. Correlation was there. And coming to the hind foot alignment, the influence of the correcting the alignment to the neutral, the hind foot shows definitely a good correlation, and there is a statistically significant correction in relation to hind foot alignment and positive correlation between the HKA and hind foot alignment. And you can see in the top corner, the right side, the pre-op angle, which is in the pathological hind foot valgus, has come to the physiological range. That is quite significant. And assessment of the functional outcome, in the pre-op and post-op, definitely there is a good improvement in the functional score in the post-op. The summary of our outcome analysis shows total of out of 66 patients on 2 years follow, majority of the around 90% of the patient showed a satisfactory outcome, and they could come into the physiological hindfoot valgus after total knee arthroplasty. Whereas in 4 patients, they had a persistent pain both in a foot and ankle, and majority of them they were in a varus knee. I will explain about our unhappy patients. The 2 patients had a tibialis posterior dysfunction, especially they had a pain in the posterolateral corner because of the persistent hindfoot valgus on the post-op. And one patient with a high BMI patients, we must have noticed they have a uh, hindfoot valgus, and though that patient also they presented with a tibialis posterior dysfunction, and we manage those patients with orthotic corrections and footwear modifications, especially with footwear, not with orthotics. And one patient preoperatively had a subtalar joint arthritis that was diagnosed preoperatively, and the postoperatively we advised for a triple arthrodesis. And we have a foot and ankle surgeon here, so we discussed with him and we suggested for a subtalar joint fusion. Yeah, and this is another interesting case I will discuss in my follow-up slide. And this is the case, the before surgery, you can see with significant varus with hindfoot valgus, and this is corrected to the physiological range with a reasonable good alignment in the post-op. And this is a quite interesting case. This is a gentleman had a left side valgus knee with hindfoot valgus and he underwent a primary total knee arthroplasty. And following the 6 months, he developed a significant laxity in the medial side. You can see there is a medial side instability with recurvatum, and probably this patient had a significant hindfoot valgus also, and this was contributing to the MCL laxity. And this patient failed with the MCL laxity in the medial side, and we revised to the hinge knee after 1 year of the primary index surgery. And coming to the literature review, and this was the article as Dr. Raj Khanna was telling, mentioning about this Dr. Arun Mullaji's paper. The persistent hindfoot valgus causes lateral deviation of weight bearing axis after total knee arthroplasty. And in this paper, they concluded in patients with osteoarthritis undergoing total knee arthroplasty, the hindfoot valgus is common and tend to persist after knee alignment. But how much of the patient there became symptomatic, and that we had to assess post-operatively. That is very important. And they calculate the ground mechanical axis that may deviate laterally due to residual hindfoot valgus. This is very important. So that's what we have to, if the patient is symptomatic or you are evaluating the patient preoperatively, in the post-op also you should follow up and see whether this pathological hindfoot valgus has become physiological or neutral, or still this lateral deviation is persisting. So that is very important in the clinical assessment. And this is another paper which shows that the hindfoot alignment is in the study they showed it is corrected significantly after total knee arthroplasty. And this is the comparison of various study. There's two papers from India. One is from Mullaji et al. And another, this is a good paper from Ganga, published by Dr. Dhanshekar Raja. And it showed that they studied the foot loading pattern and hind foot alignment, and both are corrected. That is very important because they claim that after correcting the totally doing the totally arthroplastic, correcting the alignment to the neutral, near neutral, 90% of the time, the hind foot alignment from the pathological will be corrected to the physiological range. And moreover, not only a static alignment, the dynamic pattern they studied, it showed the foot loading pattern. That showed that the lateral distribution pressure has become medial. So the totally arthroplasty realignment not only corrects the static alignment of the hind foot, it also changes the dynamic alignment, basically biomechanics of the hind foot. That is very important. And our study shows both ankle and hind foot pain can contribute to patient dissatisfaction, but once you correct, this will become this will change, and the patient will also improve symptomatically. And the evaluation of ankle is essential in pre-op and post-operatively if the patient is symptomatic. So our study presents a more holistic analysis of influence of total knee arthroplasty in ankle and hind foot alignment, and it is the first study to evaluate physiological and pathological hind foot separately. So the strength of our study, uh, it was a comprehensive functional and radiological outcome analysis was done at 2 years follow, and majority of the studies they are done in the up to 6 months follow was there. And we discussed about our complications and management, and follow up was done up to 2 years. The limitation of study, it is done in only single center. The other deformities we didn't include in our study. And these are the various footwear modification options we opted for the hind foot malalignment. Number one is a medial arch support with a medial wedge. And the third option is a medial arch support with insole. And in footwear modification also done with medial wedge. And in severe cases, we are given a double medial wedge under footwear. And this is we developed an algorithm, the preoperative clinical and radiological assessment, and grade for OA with the ankle and hind foot pain. If the knee pain is more than ankle or hind foot pain, and generally we do because this is a in the within the physiological or pathological, usually 90% of the time it will correct to the neutral or with the physiological pain. So we can go ahead with a total knee arthroplasty. Suppose for ankle or hind foot or symptomatic, so we have to assess whether this patient requires any ankle or any subtalar fusion, then you have to decide accordingly. This algorithm will be very helpful. So you have to address ankle first. Otherwise, if it is in only the tenderness pathology secondary to the any ankle or hind foot issue, you can go ahead with total knee arthroplasty and reassess post-operatively, and you can correct the residual hind foot malalignment with a footwear modification. So conclusion of our study uh, shows that the TKA improves functional radiological outcome in ankle and hind foot, whether it is in a mechanical or robotic always consider a ankle and hindfoot in your alignment strategy, and always be mindful in valgus knee with hindfoot deformity. So this is our recommendation. So especially in an orthoplastic surgeon, we have to examine the foot and ankle preoperatively, and also in the postoperatively the patient is symptomatic. So instead of calculating HKA, we should take this as a what we discussed as a HK hindfoot assessment. We should change it as a hindfoot assessment should be there. Thank you.
Yeah, thanks, Yuvraj. That was very nice. I've heard this before, but so you are saying that if a patient with the varus knee comes with varus hindfoot, what do you do? Do you do anything different in surgery or post-op?
But majority of the case, what we calculated was within the hindfoot valgus, Arun.
Yeah. So that is a
Yeah,
natural compensation
natural,
you're
yeah,
saying,
natural
and most of
compensation.
that gets corrected after surgery, right?
Yes,
That's the
exactly,
thing. So
exactly.
if it is the opposite, meaning if the
Hindfoot
patient, the
valgus.
one patient you showed first, had a
Yes.
varus knee and a varus hindfoot. So in those cases, is there something that we have to watch out for, or correct differently, or do something different? What is there some suggestion from your side?
And actually, we didn't exactly look into the hindfoot virus correction, but we routinely follow
Okay.
the same neutral mechanical alignment correction in that. But the hindfoot virus patient, probably if it is in a very significant, they'll be not happy post-operatively. But we
Okay.
didn't do any specific corrections in the hindfoot, and other than the footwear modifications.
So you had some patients with varus and hindfoot varus, I mean knee varus and hindfoot varus. There were some patients, right, in your cohort?
Yeah, but it was very less, very less. Only I think only one
Okay.
or two patients only. Yeah, but we didn't
Okay.
change our.
Or let's say there
Uh,
is a,
yeah.
you showed one valgus knee with a valgus hindfoot that required revision, right?
Yes,
So that
yes.
is a, I mean, and so those patients, would you suggest something different? In those patients, are you suggesting that we use a medial heel wedge post-operatively? Is that something
Yes.
that you're
That
suggesting?
particular patient, we recommended a medial uh, raise on medial wedge also, medial arch with medial wedge. But the patient, he didn't follow. And especially when the patient started walking, there's a lot of strain which is in the MCL, and ultimately it failed actually. Really, we suggested for a foot
Okay.
correction also, foot correction in that particular patient, but the patient didn't turn.
Okay.
Yeah.
So in such patients, why don't we overcorrect by 2 to 3 degrees? Instead of asking the patient to comply to something, so why don't we overcorrect and put it in a 2 3 degree of varus so that it can compensate for the hindfoot valgus?
Um, I know, but we can overcorrect it, sir. But thing is that either it is a neutral or overcorrection, definitely will make you to the neutral one. But already this patient had a significant valgus in the pre-op itself. We don't want to overcorrect again because that is the problem there.
No, even otherwise,
I'm talking
when
about
I
this
do
valgus.
valgus knees, I try to make sure that 1 or 2 degree of varus is okay. Just
Yeah.
leaving it in 2 3 degree of valgus, I personally, it concerns me actually, and especially when there is a hindfoot valgus like what you told. Now hereafter we have to look for all these hindfoot valgus, especially in valgus knees,
Yes, sir.
so
Yes.
that the chance of recurrence is high. But still, if you ask me, in such cases, probably I will just overcorrect 2 to 3 degrees,
Okay.
so that the final alignment will be neutral,
Okay.
so that the ball is always in our court. So we can make sure that the ball is in our court.
Sir, but it's other way, no, sir. Valgus knee, you should can error in a valgus side, not in the varus side.
That's the new
No,
thinking, Mithun. So
Uh,
the traditional thinking has been to kind of overcorrect the deformities, like what Raj is saying. We used to give 3 degrees valgus instead of the 5 degrees valgus, so that it is not left in residual valgus. That was the initial thinking, maybe I would say 10 years back. But now with CPAC and everything, we are I think moving away from overcorrection towards undercorrection,
Under
right?
correction, yeah.
No,
But
no. See, by meaning not everyone is moving.
I mean,
Those who want
okay,
to
we
move are moving.
moving means, yeah, I agree, Raj. I mean, there are still hardcore mechanical aligners like you. I
Yeah.
understand, but generally, I mean, there has been, if you look at the overall move, a lot of, compared to 10 years back, let's say compared to 2015 to 2025, if you look at surgeons, overall 100 surgeons, a lot of them have moved towards undercorrection than overcorrection for the last 10 years, I'm saying. Whether
Okay.
this is right or not, time is going to tell.
Only
But
time has to answer.
yeah,
You're
I'm
right.
just stating the trend. I'm not saying whether that is right or not, but that's the trend, a recent trend. Might be wrong, it might be right.
I don't suppose if you in 2025 you get such kind of case in valgus knee with hindfoot valgus, what is your alignment philosophy there?
So I think here, if we make sure that the medial space is not opening up too much, then it should be okay. So I think a preoperative stress view and MCL balancing at the time of surgery is important. So in a lot of these cases, MCL is kind of overstretched, and it is very difficult to over release lateral side so much so that it becomes exactly balanced. So in those cases, I would even initially, if MCL is quite lax, I would go in for a constraint insert in these patients.
Okay.
No, he is asking about the philosophy.
Philosophy, alignment, maybe because you
Yeah, I mean, like I'm still. I don't overcorrect, but I try to bring it as close to. Anything within 3 degrees is okay for me.
Functional.
So if it is valgus, I would try to bring it within 3 degrees of valgus. If it is varus, then I would try to bring it within 3 degrees of varus. That is what I currently do.
Okay.
Dr.
Yuvraj,
That's a very nice presentation. Thank you very much for sharing.
hello.
So I have a couple of questions. One is, how many of your patients were like in a kind of physiological pes planus or a pes valgus, and how many of them were actually a pathological, tibialis posterior dysfunction with an adult onset pes planus? Did you think?
So the physiological, the valgus for the majority of them were in a physiological valgus. So around 55% of the group in our study, they came as in a physiological valgus within 2 to 6 degrees. And around 40% of the group, they had a pathological valgus. So more than 6 degrees. And the tibialis posterior dysfunction is around 6 to 8% in the dissatisfaction group.
So therefore, you could say that only 6 to 8% of the patient preoperatively had hindfoot pain, is it? Or
Yes, sir. Yes. Only those small group of the patient they got a symptomatic
hindfoot?
for hindfoot pain.
And so
Radiologically, they had the majority of around 40%. Radiologically, they had a pathological valgus, but all the pathological valgus they are not symptomatic.
correct. So presumably, if the patient has a hindfoot valgus, would you be more, more aggressive in your correction and bring it to like a bit of varus in the HK axis? Is that a kind of a takeaway message you might give, or what is your takeaway message from this?
That the message you try to achieve the neutral and try to avoid undercorrection. Come to the neutral so that this neutral correction will take care of your hindfoot valgus to physiological valgus.
Oh.
Majority of the time.
Good. Thank you.
Yes.
Is that applies for both varus and valgus, or?
Yes, Kalai. Yes, Kalai. But our study group, predominantly we included varus, but definitely we need good numbers to say in valgus knee.
Most of the time, like patients have discomfort with the varus ankle deformities we see routinely, but most of the time they get corrected. That's what we believe, and we have been seeing only the HK axis. The axis which you told, we don't have any software tool to, even in robotics, we don't have any software to include that in a pre-operative manner so that to understand at least for a planning session. And mostly the valgus knee patients, they complain, and mostly those are like have the flat feet, which they later the progression into the subtalar and ankle arthritis are quite common. And number of patients who get converted into ankle fusion is also more after TCAR in the valgus area.
Valgus.
But
Yeah.
in the varus, we do routinely, like that's what most of us we don't do. Like each surgeon, they will be doing like hundreds and hundreds, but number of ankle correction they have done
Very
following varus knee is very less.
Yes, very less.
Because of a varus, because of ankle deformity, the failure in the varus is relatively less compared to the valgus.
Yes.
So like maybe it's more of a dynamic thing, which includes we have to take in account of both the hip as well as the knee as well as the ankle.
Yes.
So most of the times valgus we are not able to correct, we leave it in under correction. That's what they fail most terribly. So we should. Okay.
Thank you, Kalai. Thank you. And recently I've gone through one paper is the alternating alignment philosophy, especially the inverse kinematic alignment, give a good correction in the hindfoot alignment. So that's what they claim actually, if they believe in alternative philosophy. Yeah. So
Then
any thoughts about this, Kalai? Doing a CPAC philosophy, updates, alternative alignment in influencing the hindfoot alignment and correction.
No, that's what we don't routinely see. Like we take in account of the ankle. We just talk with the HK axis and along with. Depending on inverse kinematic, told as just like Rajkana mentioned, like he would preferably do the correction if he don't want to touch the tibia. That's what they also Philip also used to advise. So he takes the cut and whatever correction he wants to do, he will change it in the femur side.
Yes.
And that's what he published.
But conventionally they'll say correct from the proximal to distal. That's what the routine. Unless otherwise the patient, especially in rheumatoid, you need a correction from the distal, especially if the ankle and hindfoot is involved. Because what happens, suppose if you are doing if the both knee and ankle is involved, if you are doing the knee first, then you are coming to the ankle or hindfoot, it will change your alignment. So you should be a bit cautious when both are involved. So in those rare scenario, you have to correct the hindfoot first, then you have to come to the knee. So that is especially in rheumatoid patients.
Okay, so just like the dual mobility in the spinopelvic area, if the ankle and knee to have a little bit play, which kind of poly will be good? A medial pivot or a deep dish or PS?
So I did all PS knee because I don't have any experience with medial pivot and deep dish with this.
I think as a kind of more of a CR user,
Yeah.
Doing a PS knee in a patient with the MCL laxity, like the valgus knee you showed, when you take out the PS, PCL acts as a secondary stabilizer on the medial side. That is also a possible reason for valgus knees to fail when they are done with PS.
Yes, sir. Yes, sir. That's a good point.
Yeah. Okay. Nice. Thanks, Yuvarajan. Thanks for coming.
Thank you. Thanks for a good opportunity, good discussion. Thank you. Thank you all.